Uh, my name is Dr. Kushal and I'm from Bangalore. Uh, what I'm going to talk today is not something new. You all would have seen this poisonings, these patients someday or the another. It is very common toxicity we see, especially from my friends from the north part of India, where the winter is very harsh and people use fire, heaters to warm the room in a closed environment. This kind of toxicity is very common is seen. Yeah. So without wasting much time, I'll just start the note. So these are the two cases we have seen within last 6 months. So let's assume that you are in your ER and this two patients have come back to you. The first patient, both patients are 30 years old female who has who was in washroom and had an LOC, hemodynamically stable on presentation to ER, but a bit drowsy, irritable. Okay. The first case, as you can see, can you guys see the ABG, VBG?
Yes, sir. Yes, sir.
Yeah. So, you see the patient, hemodynamics were stable, saturation was 100%, and you have asked the sisters to put a line, do an ABG, VBGs. The first patient, this is the VBG that was noted. As you can see, pH is 7.09, base depth is -15, PCO2 is 40, PO2 is 23, you know, lactates are 17. Okay. So what do you want to ask to this patient? Quick history before you decide any treatment. What do you want to ask this patient? Any particular history you want to ask to this patient? So she was in washroom, suddenly collapsed. The relatives noticed the sound, broke the door, shifted the patient to ER. She's a young lady, no comorbidities. What do you want to ask quickly? It's not judging you, anybody. Just a quick note. We all are here to learn. Can you, looking at the ABG, what particular history do you want to ask? Anybody? You can write also. Hello? Anybody? Okay. Okay. So, okay. So first thing what you need to ask is, patient was in washroom, patient has collapsed. Why patient has collapsed in washroom? What can be the reason of that collapse? Anybody? One answer at least, guys. Can you see this COHB, this particular thing? Can you see this? Yes, gas geyser usage. Very good. What kind of geyser usage? Gas geyser. Gas geyser usage. So you have to, the first question, it should, looking after the ABG, looking at the ABG, the first question that can come to you is it a gas geyser? Is it a gas geyser or not? Okay. So this one particular thing you can see COHB, that is carbon monoxide carboxyhemoglobin, that what is we are concerned about. So it is a gas geyser syndrome. Probably the thing you have to ask is whether there is a gas geyser inside the washroom, because what happens is whenever there is a gas geyser inside the washroom to heat the water, the gas that comes out of the gas geyser is an incomplete combustible gas. Okay, it has an inadequate oxygen inside the washroom, and that's why it releases something called as carbon monoxide. It releases a lot of things, but one of the toxic component is carbon monoxide, and this is what is the carboxy hemoglobin. Okay, the second patient, same history, hemodynamically stable, 30-year-old female, collapsed in the washroom. They have realized that patient has collapsed. Patient comes to us. You notice that patient is irritable, drowsy, and this is what the ABG VBG turns out to be. Anybody can see anything in this? Lactates are again 14. What particular thing a young female could have collapsed? lot of things, but yeah, one particular thing inside the washroom. Okay, so let me tell, I know this is quite hard. So this two patients have come to us within similar age group, similar history, both were in washroom, but this particular, the second case, you can see it was a epilepsy patient. Okay, so it was kind of a hot water epilepsy. If you would have seen the patient, whenever patient turns on a hot water, takes a bath, especially a head bath with hot or warm water, patient has hot water epilepsy. Patient would have seizure and would have fallen down. So the first history you ask in the second patient is probably a epilepsy history, especially a hot water epilepsy. Okay. So as you can see, both similar age group, but different diagnosis. Okay. Okay, so coming to carbon monoxide is a clear odorless gas that is a product of incomplete combustion. Incomplete combustion means there is, inadequate oxygen or inadequate ventilation where the patient is present. Okay, so this kind of patients usually will come to us when patient will be sitting in either in a garage or in a closed room, closed door space. Yeah. So carbon monoxide is one of the leading causes of poisoning worldwide. United States, nearly 50,000 emergency visits are seen with the carbon monoxide poisoning. Indian data is missing in this thing. What are the most common cause? You can see a fire, any burning thing with inadequate oxygen, inadequate ventilation can cause carbon monoxide poisoning. So fire, heaters, car engine, portable generators, charcoal grills for barbecue. Paint removal is very interesting thing. So what happens is there is no burning in paint removal. Paint removal has something called as methylene chloride. This methylene chloride, whenever inhaled, usually after 8 hours after the exposure of this methylene chloride, it converts to carbon monoxide in the body. This conversion occurs in liver. Yeah, this conversion occurs in liver, and that's why what happens is after the paint removal application at home or somewhere else, patient will come after 8 hours to 10 hours of the exposure to paint removal. Okay, coming to the pathophysiology, there are many pathophysiology mechanisms, but three main mechanisms have been recognized. The first mechanism, as we all know, is the formation of carboxyhemoglobin. What happens is, as we all know, carbon monoxide binds to the hemoglobin with an affinity of roughly 200 to 250 times the oxygen. That's why it competes with the oxygen to bind with the hemoglobin and replaces the oxygen, thus by reducing the oxygen carrying capacity of the hemoglobin. Okay, finally, this reduction in oxygen carrying capacity will lead to tissue hypoxia. Okay, the second mechanism is inhibition of cytochrome C oxidase. So what happens is this carbon monoxide binds to the heme moiety, or one part of the cytochrome oxidase, affecting the function of this cytochrome C oxidase and resulting in electron transport chain inhibition and mitochondrial respiration inhibition. Okay. The third most common pathophysiology mechanism is a local inflammation. So what happens is patient the carbon monoxide, somebody is writing. Can you avoid writing? Yeah. So what happens is carbon monoxide enters the body by the lung, and what happens is this carbon monoxide will cause a local inflammation cascade to initiate. This local inflammation will cause damage to the lung parenchyma, okay, leading to local damage to the lungs. Okay. Symptoms, as you all know, it affects almost all parts of the body, all systems of the body. One of the most common symptoms is in carbon monoxide poisoning is seen neurological. They say that 91% of the patient who have the carbon monoxide toxicity comes to comes to the ER with headache. Okay, headache is a very common symptom. The second most common symptom is dizziness or giddiness. Roughly 77% of the patient will have this kind of symptoms as giddiness, double vision, dizziness. Okay. Also, in a severe carbon monoxide toxicity, patient can go have a seizure, delirium, coma, and can have loss of consciousness. The second most common system to be involved is cardiopulmonary. Most common symptom is breathing difficulty, that is dyspnea, chest pain. Patient can have arrhythmias. Patient can also have a syncope. Okay. The third most common system to be involved is a gastrointestinal is GI system. Patient will have nausea, vomiting, abdominal pain. Yeah. So this is the signs of carbon monoxide poisoning. As you can see, headache, nausea, dizziness, breathing difficulty. Patient might collapse, as this happened in our patient. Loss of consciousness. Yeah. So let's say a patient comes to you, and patient is not going to tell you directly that he has carbon monoxide toxicity. You have to figure it out in your ER. Okay. So what are the clues to look out for carbon monoxide toxicity? As we mentioned till now, history very important. Patient will be in a closed space. Patient will have a fire fire nearby with inadequate ventilation. This can aggravate carbon monoxide. Symptoms, as we saw, signs and symptoms, as we discussed, neurological is the most common, followed by CVS and GI. Patient can also mild carbon monoxide toxicity can also have flu-like symptoms without fever. Okay. Next, patient comes to your ER. You do an ABG. The first clue that can come that has to be from the ABG is your saturation gap. That means the pulse oximetry will show 100%, but your PaO2 in the ABG will be very low. This is not only seen in carbon monoxide toxicity. This is seen in variety of situations, but this is the first clue that can trigger your brain to find out that it is a carbon monoxide toxicity. Second thing is hyperlactemia. Carbon monoxide toxic patient will have high amount of carbon monoxide, low amount of oxygen. That means patient will have more of aerobic respiration than aerobic respiration. That means in anaerobic respiration, lactates are high. Okay, so that is the reason of hyperlactemia in CO toxicity. Coming to non-invasive co-oximetry. So as you can see in the right, there is one figure I have I have put it here. You see, this is a finger, this is the pulse oximetry. Okay, and this is the tip of the finger of the patient. So what happens in pulse oximetry is there are two light sources. One emits red light, the second emits infrared light. Okay, and you can see on the other side there are sensors available. So what happens is whenever there is an oxyhemoglobin abundant in the finger, this infrared light will be absorbed by oxyhemoglobin, and this absorption will be detected by the sensors. Okay, and that's how you get a perfect saturation on the monitor. Okay, this is what the mechanism of pulse oximetry is. Now in co-oximetry, what happens is, as you can see, there are two lights that comes out. There is one red light, there is one infrared light. There are two lights with different wavelength. Okay, now what happens in co-oximetry is there are seven wavelength lights that come out. Okay, instead of two, there are seven wavelengths. Okay, so that's why it measures lot of other parameters apart from saturation or oxyhemoglobin. What other parameters it measures? It measures deoxyhemoglobin, it measures methemoglobin, it measures carboxyhemoglobin. Okay, so that's how it measures. A lot of seven parameters actually it measures. Okay, next is your ABG VBG routine. As I showed you in the start, we can look for carboxyhemoglobin in your ABG VBG as well, and you will be able to find. Okay. Regarding the symptomatology of carbon monoxide toxicity, the toxic levels are very disproportionate to the symptoms. Though the theory book says that the percentage of carbon monoxide what percentage of carbon monoxide is present, that the symptoms can be seen, but on ground the reality is very different. The toxic levels are very disproportionate to the symptoms. Yet theoretically we might get a clue looking at the symptoms that what percentage of carbon monoxide is present in the body. So as you can see, above, ideally mild to moderate is below 20, severe is below 25. So 25, about 25% of carboxy hemoglobin is what considered as severe carbon monoxide toxicity. Okay, so above 50, usually patient collapses, patient has a respiratory failure, and 70 and death is usually seen. Okay, looking, so we all work in somewhere or other. We have worked in a corporate setup, and whenever there is a neurological system involved, we always think of an MRI. You know, even though we know that it is mainly a metabolic cause or maybe some toxicity, we definitely do a simple plain screening MRI to make sure that we don't miss any other diagnosis. Okay, so any patient comes to us, MRI is not an indication to do, especially in carbon monoxide toxicity. But let's say if we do, we can recognize carbon monoxide toxicity by an MRI as well. How do we do that? So looking at the right image, left image, the first image A, you can see this. So this is a flare image where you can see there are two round structures. So you can see this is called as globus pallidum. This is a part of basal ganglion. And in carbon monoxide toxicity, this is very peculiarly seen that there will be hyper intensity of this both structures, that is globus pallidum, sparing the other parts of basal ganglion. If it is a stroke, then basal ganglion is involved completely. But if it is carbon monoxide toxicity, it is only the globus pallidum that is involved. The middle picture, as you can see, this is a diffusion weighted image of an MRI. As you can see, this has an extensive bilateral diffusion restriction of both the hemispheres. Okay, it looks like a stroke, but after correction, you can see the last image. This is after the correction, and you would have seen that it has completely reversed. Okay, so these are the radiological findings of carbon monoxide toxicity. Okay, so finally, critical thinking is very important in such kind of patients. Patient will give some clues here and there, like patient will have flu-like symptoms with some neurological symptoms and hyperlipidemia and EBG changes, plus the history, especially in winter places where there is low temperature and patient use fuel burning heater or fire in a closed environment, in a closed space to make the house warm. Okay, this is the history what you look for. Always ask the history and the non-specific symptoms which doesn't add up and make a complete diagnosis to you. So these are very vague symptoms with a vague history. You have to look for carboxy hemoglobin. Okay, coming to the treatment part, mild toxicity. So what is the main aim of giving the treatment is in a mild carbon monoxide toxicity, your main aim is to replace the carbon monoxide with oxygen. Okay, how do you do that? You do by giving 100% oxygen. How do you? Again, by three ways you can give. The first way is you can use a high flow nasal cannula, HFNC, with 40 liters per minute and setting up the FR to 100%. You can combine the nasal cannula with your NRBM mask, both setting up at 15 liters per minute. But what studies have shown that the most effective way to reduce the carbon monoxide in the body is your CPAP and BiPAP in mild CO tox, mild carbon monoxide toxicity. Okay, it is even higher effective than your HFNC. Coming to severe toxicity, now our goal changes a bit. In severe toxicity, where the neurological involvement is there or some end organ involvement is there, what you have to do is you not only have to replace the carbon monoxide from the hemoglobin, you also have to reduce your oxygen consumption because there is very less oxygen in your body. So your oxygen requirement has to be reduced apart from replacing the carbon monoxide from the hemoglobin. Okay, so how do you do that? You do by intubating the patient and sedating the patient. Okay. What is the ventilation? You always tend to increase, apart from keeping 100% FiO2, regardlessly of your PaO2, what you have to do is you have to increase the minute ventilation. You can do it by either increasing the tidal volume or respiratory rate. Again, if you are increasing the respiratory rate, make sure that the patient doesn't go into alkalosis. Okay, you have to keep a target CO2 level at 35 to 40 when you are increasing the minute ventilation. Okay, deep sedation is always preferred in severe carbon monoxide toxicity. Why? Because it reduces the cerebral metabolic activity and reduces the oxygen demand of the brain. If at all the patient is unstable, you can use ketamine. If the patient is stable, patient tolerates well, you can use a propofol infusion. Okay, paralysis. Paralysis is always preferred in severe toxicity because, again, as I told you, it reduces the oxygen consumption not only by the respiratory muscles but other vital organs like brain, and it improves the perfusion to all the vital organs, including kidneys and brain. Uh, Temperature control, as you all know, hyperthermia increases the metabolic oxygen demands, and thereby, there will be huge mismatch of your oxygen demand and supply in such kind of patient. So always make sure that either you keep the patient as a normothermia or you keep the patient as hypothermia. One of the case series that was published a few years ago, they have kept the patient at a therapeutic hypothermic level of 33 degrees, and this have shown to have a reduced brain injury and a good clinical outcomes in at least 3 patients. That's what the case series was all about. PRBC transfusion. So the concept of PRBC transfusion, like an exchange transfusion, what is that? To replace the carboxyhemoglobin with the new hemoglobin from outside. This is called an exchange transfusion, but it doesn't have a good high level evidence to support it. What happens in the exchange transfusion is that it takes usually 6 to 8 hours to do an exchange transfusion. By the time already, if you give 100% oxygen, already the carbon monoxide would have gone from the body. Okay, so there is no role of exchange transfusion. Yes, but the American College of Emergency Physician have given a guidelines in 2017, I think, if I'm not wrong. You can go and check once if, yeah, I'm not sure about the year, but it was 2017. They have told that in a patient with anemia, the hemoglobin target should be maintained above 10, especially in carbon monoxide toxicity. Okay. Above that, there is no role of transfusion and there is no role of exchange transfusion, according to American College of Emergency Physicians. Okay. Coming to hyperbaric oxygen therapy. So we all know what is hyperbaric oxygen therapy. Sorry. So, okay. So what happens in hyperbaric oxygen therapy? They give 100% FiO2. They give full oxygen with some atmospheric pressure, with some pressure. Okay. So oxygen competes with the carbon monoxide, binds to the tissue and removes oxygen competes with this and removes the carbon monoxide. Okay, usually what happens is if the patient comes to us with carbon monoxide toxicity, and if you keep the patient awake in the on a room air at 21%, the half life remains around 5 hours. But if you give 100% FiO2, the half life is around 1 hour of carbon monoxide. But if you increase the pressure along with the FiO2 of 100%, you can see the carboxyhemoglobin half-life reduces to around 20 minutes. Okay, so there was one major study done in 2020, 2002, if I'm not wrong. They have done that study, which is called as Weaver et al. Study. They have compared 152 patients of normal oxygen, that is 100% mask oxygen, with the hyperbaric oxygen therapy, and they found out that um, you know um, the outcome of the hyperbaric oxygen therapy was much better if if the patient's use was within 6 hours of onset. Okay, so let's say the exposure is at 10 o'clock, you have to use it within 4 o'clock in the afternoon. Okay, after that, the hyperoxia risk was much more higher, and the what you call the outcome was not much efficient with the hyperbaric oxygen therapy after 6 hours. Hyperoxia again is a concern in HBOT therapy. What happens is it causes first of all cerebral vasoconstriction, renal vasoconstrictions. It can cause oxidative stress to the cells and finally to the cell death. So we always have to balance and walk. So even the American College of Emergency Physician guidelines says that you have to, if at all you have an HBOT machine within your premises, you have to use within first 6 hours. After 6 hours, there is no use of it. Okay. Coming to the indication, what are the indications of hyperbaric oxygen therapy? Loss of consciousness is an indication, even though the patient is conscious now, with a higher carbon monoxide toxicity, with a severe carbon monoxide toxicity, even the patient is conscious now, but patient had a transient LOC. That itself is an indication to use an HBOT for the patient. Any neurological symptoms, any cardiac ischemia, severe carbon monoxide toxicity, that is COHB of greater than 25%, severe metabolic acidosis, in spite of giving restriction measures, the acidosis remains, that is an indication of HBOT. And in pregnancy or pregnant patient, the CAHB threshold has to be 15 and not 25 for hyperbaric oxygen therapy. Okay, so there is a concept called isocapnic hyperventilation. So what happens is, before the hyperbaric oxygen therapy was even invented, this isocapnic hyperventilation was being used. And now again, since the HbO2 is not available in a lot of hospitals, especially private hospitals and government hospitals, this concept has again resurfaced, and there are few studies that is going on right now whether this is effective or not. So what is the concept? Let's say you hyperventilate the patient, you are increasing the minute ventilation. Why? How? By increasing the respiratory rate. Okay, once you are increasing the respiratory rate, what happens is the carbon dioxide washout happens. So your PaCO2 reduces, and that causes respiratory alkalosis. This is what something we don't want. Okay, so what you do, you give some small amount of carbon dioxide along with your oxygen with every breath, to make sure that your PaCO2 remains normal. That is called as isocapnic hyperventilation. So you hyperventilate the patient, but giving some amount of carbon dioxide along with your oxygen while you are giving the breaths. Okay, so this concept is, I think, might come again, resurface again within maybe few years from now, as carbon dioxide is cheaply available everywhere in every hospital, but your HBOT machine is not. Okay. Coming to the newer therapies, newer therapies includes there is something called as hemo CD twin compound. So these are all new therapies, and these are all new preclinical trials that are going on. So there is compound called as cyclodextrin heme complex. It has to be given through IV, and whenever you are when you are suspecting a CO toxicity, and when you show that a COHB is more than 25, this compound can be used. So what it does is it binds to the carbon monoxide with the extreme high affinity, even higher affinity than hemoglobin. And that's how what happens is it takes the carbon monoxide from hemoglobin, and the carbon monoxide attaches to this complex, that is cyclodextrin heme complex, and it can be easily thrown out from the kidneys. So this trial is going on. I'm not sure how much it will succeed, but let's see. There is a portable HBOTs, new companies, new brands have come up. So like how ECMO machine works, whenever you have a problem in any of the ICUs, a team comes with a portable ECMO machine, fits there and starts the ECMO. The same concept goes for the HBOT as well. So one team will come whenever you're suspecting such kind of toxicity or any other indication to use HBOT. Your team will come, attach the whole HBOT machine there, and you can start using your hyperbaric oxygen therapies there itself. Okay. There is one more antioxidant that is called as MitoQ, that is mitochondrial targeted antioxidants. This is also in preclinical trial. What happens is, especially in cyanide toxicity or your carbon monoxide toxicity, one of the main pathophysiology point is that it inhibits cytochrome C, and this antioxidant prevents this cell death because of inhibition. Let's see if it works or not. These are all in preclinical trials. Okay. So I think with that note, I'll just end here. The take-home message for any kind of toxicity, any kind of carbon monoxide toxicity is early recognition is the key to the early recovery. Early restoration, like your airway, breathing, circulation has to be maintained. A normal hemodynamics has to be maintained. Whenever there is a patient with severe carbon monoxide toxicity, you increase the minute ventilation, but make sure you do get a respiratory alkalosis. Okay, sedate the patient properly, paralyze the patient properly to reduce the oxygen requirement, avoid hyperthermia, anemia, and alkalosis. And your HBOT is always there for you, but it stars. These are the key points and key guidelines of even American College of Emergency Physician for carbon monoxide toxicity. So I've taken few points from Goldfrank, I've taken from Tintinelli, and from Criticare sites. So so we all have seen these cases. Anybody else wants to add some point which worked for them, which I have not mentioned here? Any specific thing what witnessed and it has worked wonders for them, for the patients?
Yeah, thank you very much, sir, for strictly sticking to the time prescribed. So really appreciate the time sense. So we'll take some questions now. If
Yes, please.
anyone is asking any question, please, this is the time for you.
So
So
do all ABG, wherever you're working, do all ABGs has your carbon dioxide, carbon monoxide hemoglobin?
co-oximetry,
Coaximetry. No,
I don't
not
think.
coaximetry. Coaximetry is very costly. No hospital gives, but your ABG machine will have that.
Okay. I don't think a lot of places have that, sir. Only in the
Yeah.
corporate setup we have that. I mean, in few medical colleges, the ABG is also not there. It will go in out of service and they don't get it repaired for a long time.
Correct.
So if nobody is asking any, one question is here. So how can
Yeah.
I,
So it gets tricky because, first of all, you have to diagnose it, whether it is your carboxyhemoglobin. Let's say if you are able to diagnose it with only history, um, it's you can ventilate, you can put on 100% FiO2 and see patient is getting better or not. You can rest it. But I think to diagnose it, you will require some COHB thing, either in coeximetry or in other than oxygen therapy. There are many, see, according to the guidelines, there is no medicine to reverse it. Okay. There's some studies they have done where they have used neck, they have used your erythropoietin to increase the RBC. They have used neck as an anti-inflammatory, antioxidant, but none are proven. So only oxygen therapy and replacement of carbon monoxide is the only therapy proven according to the RCTs.
so yeah. So just to summarize, so the patient coming with hypoxia will not have hypoxia, of course. The SpO2 and PaO2 reflect the oxygen-bound hemoglobin and dissolved plasma hemoglobin. So I'm sorry, oxygen. So that's why they might not have it. So the patients coming will complain of headache and might have a history where they have closed space fires or house fires. They are using warmers. So all of these history will give us an idea, and in these patients, we have to have a suspicion of carbon monoxide poisoning, and we have to send lab confirmation for them with COHB. And the treatment, of course, will be FiO2 100%. So because, like sir said, on room air, FiO2 21%, it will be 4 to 6 hours of half-life for this carboxyhemoglobin. But in 100% FiO2, it will be around 60 to 90 minutes. But in hyperbaric oxygen therapy at 2.5 to 3 atmospheres, it will be 20 minutes. Right. So we have to have a lower threshold to have a suspicion for this one. And the ABG will show a metabolic acidosis with elevated lactates and because of tissue hypoxia. So the question where we don't have COHB is unavailable, maybe we can send for serum lactate levels and have a suspicion among the differential diagnosis. The differential diagnosis will obviously be others such as cyanide toxicity, hydrogen sulfide, methanol, which is also causing acidosis, and neurological changes and visual changes, methanol toxicity, and methemoglobinemia will also have a happy hypoxia in these patients. So all of these will be our suspicions and differential diagnosis. Just go ahead with oxygenation. But also patients will present sometimes with flu-like symptoms in all the household, like all the family members of this household might come with the same flu-like symptoms, cough and other kinds of headache and eyes or watery eyes. So all of these will give you a sort of clue. And pregnants are more susceptible. So we have to have a lower threshold for pregnancy where we have this indication to start HBOT will be co-HB around 25 for normal and 15 to 25 in pregnant patients. Persistent symptoms, loss of consciousness, neurological deficits, severe acidosis less than pH less than 7.1. This is an indication for HBOT therapy, and cardiac ischemia is also an indication. Right. So that is all we can summarize. Apart from that, if you somebody had a question in mass exposure incidents involving CO, like industrial leaks, what triage protocols are most effective for identifying high risk patients who may deteriorate despite initial stability? Yeah, very well formed. I mean, actually, the triaging of these CO patients is also important, and I think we have to differentiate the CO based on the HbCO available, and we can do it as mild, moderate, and severe. So at around 10 to 15 and 15 to 25 and above 25. Right, sir? Kushal, sir.
Yes, sir. Yes.
So that is the
Normal
triaging.
usually will have some roughly 10 as a normal thing, but
Yes, sir.
in a normal patient, it is usually less than 5.
So high risk patients are what I have just mentioned, the patients with neurological symptoms and pregnant females, those with severe metabolic acidosis. These are all high risk patients. So we should, and also history of loss of consciousness or seizure like episode in the field, or any cardiac ischemia ongoing. So all of these are our high risk patients. So we have to look at the COHB levels and then look at the signs and symptoms and then triage them accordingly. So that will give us a proper triaging in mass casualty scenarios, mass exposure scenarios. So this
So there is
summarizes.
no particular triage protocol for carbon monoxide toxicity. It is a general mass casualty protocol like START, what you can use.
Yes, sir.
But yeah, all other patients will have the same kind of symptoms
Yes.
in such kind of
So
things. Yeah.
we start oxygen in case of such exposures or fires. This starting oxygen in the field will be beneficial, but also we have to rule out any nasal burns and all of that, singeing airways, all of
Yeah.
that. So
Correct.
again, it's a clinical decision, case to case. So thank you everyone for joining today. We'll record this and upload this on YouTube for you to review it later. Really
Thank you.
thanks Kushal sir again.
Thank
So
you.
really thankful to all of you guys for joining. Next week we're going to meet on Saturday, and we're going to discuss about counter terror medicine, which we have had a brief introduction recently. So this is a tactical combat casualty, tactical combat casualty care, and this is lecture is presented by a very famous faculty from Israel, Dr. Ahmed Nama. So he has first-hand experience of terror medicine and counter-terror medicine and all of these. So we're really eager to get that discussion next week. So I hope you all will join. Thank you very much.
Thank you. Thank you
Thank you,
all.
sir.
Thank you for
Bye. Bye,
joining.
sir.
Bye bye. Thank you.